Difference between dead space air. So this respiratory system, the respiratory system organs, we know that it contains air. Okay? These respiratory system organs, they contain air from your nose all the way. There is air in there. But I want you to know about dead space air. What you need to appreciate is only the air that is in the terminal bronchioles. It's called terminal bronchioles. Right here. Only the air that is here in the terminal bronchioles participates in gas exchange. So the other air beginning from your nose, they don't have anything to do with, they're just there. So that's why it's referred to as dead space air, because you don't use them for gas exchange. And there are two types of dead space air: anatomical dead space and physiological dead space. Anatomical dead space is the anatomy. You can't change that. You can't increase or decrease. Beginning from the nose, it's the anatomy, right? The air that is found in the nose, all the way down here, nose, your pharynx. This is all dead space air. They don't participate in gas exchange. Only the air where? In the terminal bronchioles. Maybe for our purposes, you should write the respiratory bronchioles. So you'll be reminded that this is the one that participates in gas exchange. So only the air in the respiratory bronchioles and the alveolus. This is the air that exchanges, participates in gas exchange. The air in the rest, they don't. Okay? There's a function, though, to the air there. It's just not being used for exchange, and you will see what the function is. There is also what you call a physiological dead space. So what you just wrote is anatomical dead space. Can you increase the anatomical dead space? No, it's anatomy, right? Can you decrease? No, it's anatomical. You can't change your anatomy. That's how you were formed. The physiological dead space now happens when a part of your respiratory part, the respiration organs, when a part of that becomes non-functioning. Let's say you have pneumonia. So there's a section of the lungs that's no longer able to participate in gas exchange. So then the air in there is called dead space. It's not able to work for you. So you call that physiological dead space. You understand the difference between the two? Okay? So can you increase physiological dead space? Yes, right? Because that's dependent on pathology. You have bronchitis maybe, so there's a plug here. So then maybe if your bronchitis is over here, there's accumulation of secretion there, then you won't be able, there's no exchange there. So that's physiological dead space. You understand? Okay? Okay. Before we proceed, there's a few things we need to appreciate with the respiratory system before we understand uh, gas exchange. Number one, hyaline cartilage. If you notice, beginning, you feel your larynx right here. We know the Adam's apple. You feel the hardness there, and I'm sure you saw it in your cat, right? You feel the rings right here. There's rings of cartilage there. So, hyaline cartilage is fairly solid, right? And what do you think is the function of your hyaline cartilage? Protection. What else? I'm thinking hyaline cartilage is very important in keeping your airways always open, right? Have you seen an oxygen molecule with hands and feet? it can't push itself inside, right? So God made our respiratory organ so that it's always open. Air is always ready to go in. Does it make sense? Okay? That's the importance of the hyaline cartilage. It keeps your airways open wherever it is present. Do you follow? However, look at, if you go all the way down, so you understand that hyaline cartilage, it keeps your airways always open. But if you go all the way down, if you look at this picture over here, look at, when you get to the terminal bronchioles, did you notice? Look at, very nice, solid, complete. When you get here, look at, it gets discontinuous, right? And then finally, do you see it right here in the terminal bronchioles? Absent. So what's here, what's left there, the wall of the terminal bronchioles, what's left is just smooth muscle.
That number 2 is the smooth muscle when it gets down to the terminal bronchiole.
There, yes, all the way up there's smooth muscle, you see, but at least here, there's that hyaline cartilage that keeps it open all the time. When you get to the terminal bronchioles, there's no more hyaline cartilage that can keep it open all the time. So people who have asthma or severe allergies, don't you ask, you have difficulty breathing, right? We know that allergies cause constriction. And that's where the constriction, do you think, if there's constriction here, do you think there'll be gas exchange? No. So can you die? Yes, you can die, right? If there's no gas exchange. That's why they always have to carry EpiPen, because what does it do? It relaxes. So it promotes bronchodilation. So what does that mean? The smooth muscles relax again, allowing opening, making sure that the airway is still open. Where is the problem? What do we worry about with, so this is bronchitis that can eventually go down and cause bronchiolitis. The problem is it can compromise gas exchange. And anatomically, you can explain that, right? Because what's absent? Hyaline cartilage. Okay? Next. Pseudostratified ciliated columnar epithelium. Pseudostratified ciliated columnar epithelium. You remember this one? Pseudostratified ciliated columnar epithelium. Okay? Columnar epithelium. This now we appreciate. There's your pseudostratified ciliated columnar epithelium. This is a typical lining of your respiratory tree. What is the importance of this one? Remember the cilia? So look at this one. And some of them make mucus. Remember the goblet cells, they make mucus, and so they line your respiratory tree. Do you imagine yourself standing up, right? My respiratory tree going down, okay? So the mucus, it settles down, right? And it serves to coat my respiratory tree. And what the mucus does, as I inhale, I'm always inhaling bacteria, I'm sure of that one. And the job of the mucus is to serve like a quicksand. It traps them, slows them down, allows the cilia to brush it up. See? And this is what happens with cigarette smoke. Cigarette damages the cilia. So you see, if it damages the cilia, the mucus is still trapping the bacteria. How are you going to get rid of it? Now you have to cough to get rid of it. Okay? With the cilia, it's constantly brushing that mucus up, and we just swallow it. We swallow phlegm all the time. Okay? You understand the importance of this one? Okay. As far as the hyaline cartilage is concerned, in the trachea or your windpipe, and I want you to look for this in the cat. You will appreciate it. In the trachea part, so this is the larynx, right? This is the trachea, this part here. So this Adam's apple up here, that's just the boundary of your larynx. So inferior to that one, that's the beginning of my trachea, and I can feel those cartilage rings. What you need to know about the trachea is directly posterior to the trachea, and you will see that in your cat, is your esophagus. This is where the food goes down, right?
Would that be a bigger hole or a smaller hole?
That's a good question. It's a hole that is collapsed because it has no hyaline cartilage. So it's collapsed. Okay? Okay. And I want you to look for this. I want you to separate the trachea from the esophagus very carefully. And you will notice that, that the cartilage of the trachea is not continuously all around. So the posterior wall of the trachea has no cartilage. It's just made up of smooth muscle called trachealis muscle. And this is very important. At least the anterior wall, being cartilage, keeps the airways open, and the posterior wall allows you to swallow your food without any pain. Painful swallowing is referred to as dysphagia. So this is what is avoided with the discontinuous ring of the trachea, of the cartilage in your trachea. You understand that anatomical modification in the trachea? Okay? Why posteriorly it's not continuous? Okay? So that's the reason. Okay. Next. Before we move on, so after the trachea, it branches to right and left bronchus, and we know that after this one, okay, it's going to go down directly to your lungs. Most respiratory infections generally affect the right than the left. The reason is the right bronchus is wider and it goes down directly. The angle right here for the left bronchus is more acute. So bacteria, if they go down, it's easier for them to just settle down here than here. There's like a sharp turn for them on the left side. But we know that if infection was able to go down by gravity very easy, you're going to have problems with air exchange very, very quickly. So to prevent that, okay, right here, you see this one at the junction between the right and left bronchus, the most terminal part of the trachea called the carina, right here, carina, which came out in the test in the past. This carina, this is the most sensitive portion of your respiratory tree. It triggers the strongest cough reflex. Why? Because if you let the bacteria very easily go down here, you're going to end up with pneumonia. Or, you want to prevent that. What you want is good air exchange. So in case there's bacteria or any kind of, have you ever had that like cough just once in a while, you just automatically cough? That's because it tickled your carina and it will just trigger the strongest type of cough. You just cough it out. That's protective, okay? And I remember that came out in the test in the past with my past classes, okay? Okay. Then finally, when we get to the alveolus, guess what? The alveolus, do you agree? Or I hope you will understand why when you get to the alveolus, look at, no smooth muscle, no cartilage. What is it? It is just simple squamous epithelium. So your air sacs look like this under the microscope. The alveolus, it just looks like this. The thinnest type of epithelium, which is one layer, right? Which is the flattest one, simple squamous epithelium. And don't you think this is very good for allowing very quick gas exchange, right? So no more smooth muscle, no more cartilage. It is just plain, simple squamous epithelium. That's why it's very important to keep that ciliated, pseudostratified ciliated columnar epithelium, make it healthy, and that carina, very important to always be present there, be very sensitive, because once bacteria settles down here, this has no way of protecting itself, okay? However, there are some cells here. So while we're here now, I want you to write down, this is the alveolus. Do you follow so far, everybody? You follow everybody? Again, I'm going to look at this picture over here, right? See, over here, we have all the structures. So we're just looking at the anatomy, the wall of these structures here, the trachea, the larynx, trachea, all of these has hyaline cartilage. We understand the importance of that one. You understand why the hyaline cartilage is not continuous posteriorly for the trachea to accommodate your esophagus. And when you get to this part here, that's the carina. I want you to remember that one. Then when it separates to right and left, you see, look at it, just keeps going, 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 going. But then when you get to the terminal part here, the hyaline cartilage becomes discontinuous until it gets absent in the respiratory bronchial part. And it's just smooth muscle, see? That's why we worry about constriction here. No problem here, it will stay open. But the problem is here. But then, look at, by gravity, if we don't, people have cough, even your babies, right? Some some people, they forget, let's say with babies, it's very easy. By gravity, any kind of secretion can very easily settle down there. And when it gets to this bronchioles part, it can easily, the secretion can irritate the wall and it can constrict very quickly, okay? Then when you get to the alveolus, look at, there's no smooth muscle, nothing. It is just simple squamous epithelium, and that's very important for you to understand. The alveolus, you notice here, is very vascular because this is where the exchange of gases happen. And what blood vessel is this one? Capillary, you remember? And do you remember the capillary is also what? What is the lining of the capillary? The capillary is made up of, does the capillary have muscle? No, it is. Isn't it simple squamous epithelium also? So this, were they, the capillary and the alveolus, both simple squamous epithelium, flat, very easy for the gases to move from one um, area to the next. Okay? Okay. While we're in the alveolus part, I want you to know that this alveolus is made up of, yes, it is simple squamous epithelium, but these simple squamous epithelium cells have names. They have two names. So they're called alveolar cells. Alveolar type 1 and alveolar type 2. So this simple squamous epithelium cells, this is your alveolus, okay? They're called alveolar cells. They make up the alveolus. And they're called type 1 alveolar cells if that is the cell where gas exchange happens. I'm looking at this picture, I'm thinking, do you agree? I'm thinking this must be alveolar type 1 here because this is the place where gas exchange will happen, right? gas exchange happens between blood and the alveolus. So this must be type 1, okay? And then the rest are called type 2, alveolar type 2. The job of the alveolar type 2 cells is to make surfactant. Surfactant. I know you're familiar with surface tension. Are you familiar with surface tension? It's the attraction between water molecules, right? That's why insects are able to walk on the water because the individual water molecules are attracted to each other, right? And you ever had your notebook wet maybe? If it gets wet, it's very hard to separate the individual pages, right? When it gets wet. That's the same thing with your lungs, okay? You remember, we talked about the pseudostratified ciliated columnar epithelium, how there's always mucus being formed here, okay? And so by gravity, do you agree? By gravity, some of the mucus, which is watery, right? It can very easily settle down here. So this is always moist. There's always water here. Do you agree? Okay? And there's a problem here, right? It's always moist, but there is no way to keep it always open. There's no cartilage here. So how will it prevent itself from collapsing? That is the job of your type 2 cells. That's the purpose of surfactant. The purpose of surfactant is to prevent your alveolus from collapsing. A collapsed lung is referred to as atelectasis. One more time. So the alveolus is coated with water all the time. That's settling from your mucus secretions from up here, okay? So it's coated with water, and we know that water gets attracted to water, to water. That's what's referred to as surface tension. So if you expose the water, they see one another, they'll get attracted, and you will collapse this lung. So we have to find a way, or we have to solve that attraction between water molecules. That's the job of the surfactant. So surfactant is a protein made by your type 2 cells. And they coat the alveolus so that the water molecules don't see each other and they don't get attracted. So does surfactant increase the surface tension or decrease it? What did you say?
Increases.
Decrease.
Decrease.
Surfactant decreases the surface tension. Okay? Increase surface tension meaning they get attracted. We don't want that
Okay.
in the alveolus. Surfactant is naturally produced by your alveolar type 2 cells during the last trimester of pregnancy. This is why premature babies run the risk of going into respiratory distress syndrome. Have you heard of that one? RDS, respiratory distress syndrome. Because premature babies, those who are born before 6 months, borderline 6 months, their lungs, their type 2 cells haven't made surfactant yet. It used to be an emergency. I remember when I was rotating, during our residency training, even internship, we would have babies born prematurely. And we have to do the ambubag. You don't do that here anymore. But it's a poor country, so we have to take turns, making sure that the lungs of the baby doesn't collapse 24/7. So we're taking turns pumping air in there using an ambubag. So
So where does jaundice come in?
that's
Liver.
different. Jaundice is red blood cell. Remember we talked
Right,
about
right,
that.
right.
That's different.
Okay.
This is air.
Does
Okay?
your liver.
Do you understand jaundice, the physiology, why you develop jaundice, everybody? Remember? Is the red blood cell So when the red blood cell dies, the liver has to process that, and then the liver has to get rid of your pigments. But if your liver is premature, like premature babies, the liver is not working yet, or alcoholics, the liver is non-functioning anymore, you have no way to get rid of the pigments. So you become yellow. So this is respiratory distress syndrome. Do you understand this one? So do you want high surface tension in your lungs or low?
Low.
Low. Don't forget, I asked that in the test. Surface tension. So what does surfactant do? That's very good. It decreases surface tension. There's another resident cell here in your alveolus called your macrophages. Your book refers to them as the dust cells, alveolar dust cells. They do some dusting work there. So in case there's bacteria, it's very easy for bacteria to settle just by gravity. It goes down. At least we have macrophages here that patrol the area all the time. If there's any bacteria, they provide second type, right? Second line of defense. Okay? So you understand the features in your alveolus?
You said type would make a protein.
No, type 2 makes the surfactant.
Which is the
Type
protein.
1 is for the exchange.
Okay, but what you said there was a name?
The protein is called surfactant.
Okay.
Okay? Okay. Another very important feature, by the way, in your alveolus, yes, there's no nothing, right? There's no hyaline cartilage, there's no smooth muscle, but right, and you have it very nice in your lab manual. You see those fibers there. That's not blood vessel. It is elastic fibers. This is very important. We're going to appreciate the function of these elastic fibers when we talk about ventilation. So there's elastic fibers in your alveolus. And you remember the function of elastic fibers? You stretch it, it goes back to its original length, right? So this is very important for us to remember when we study the physiology of respiration. Okay? Okay. Finally, I want to look at the coverings of your lungs. So we know that the lungs occupy the thoracic cavity, you remember, and it shares this thoracic cavity with your heart, okay? And the lungs are covered by membrane also. So you call that pleura. In the heart, remember, it's called pericardium. So in the lungs, it's called pleura. The membrane that covers your lungs is pleura. And there's two layers. The parietal pleura and the visceral pleura. Parietal pleura and visceral pleura. Okay? Parietal and visceral pleura. Okay, very important. The parietal pleura is actually stuck to the wall of your thorax, so it's right here. The visceral pleura is stuck to the substance of the lung. Can you picture in your head? Oh, so here, right here. See? The visceral pleura is stuck to the substance of the lungs, and the parietal pleura is stuck to the wall of your thorax right here. Okay? So, and in between the two, there's fluid there called pleural fluid. And we know the function of the fluid, right? For friction free, it's not difficult when you breathe. But there is fluid there, the pleural fluid. Now, we know again water has surface tension, right? Here, in this pleura, We want the high surface tension. In other words, even though there's fluid here, we don't want the fluid to be like here in this water bottle. The purpose of the fluid here is to stick those two membranes together. Meaning, high surface tension you want here. You like that high surface tension that sticks the parietal and the visceral pleura together. That is very important for you to appreciate. When you inhale, doesn't your chest expand, right? So look at, I told you that the visceral pleura is stuck to the lungs and the parietal pleura stuck to the thoracic wall. So when you expand, when you inhale, you expand. Isn't that going to expand the lungs to let a lot of air in? Because why? They're stuck together. Like an accordion, right? So, what is the surface tension here? High or low?
High.
High. In the alveolus? Low. You see the advantage, right? We want it high here because we want to expand the lungs. Because we want, that's the purpose of breathing. You want to breathe in air. So you want to expand the lungs. You understand? There are a few problems that can happen in your pleura right here. I'm sure you've heard of pneumothorax. Have you heard of this one, pneumothorax?
Mm-hmm.
Air in the lungs, like maybe stab victims. Don't they say if you have a patient who stab victim, you never pull out the knife, right? You don't want to pull out the knife because you're going to introduce negative pressure and air just goes in. When air comes in, okay? When air comes in, can you picture that? When air comes in, you're going to push the lungs, you're going to collapse this lung, right? Promote atelectasis. So you're going to compromise exchange here. The surfactant is just so they can't see each other. But if you push this lung, push it, so you're promoting the contact between the water molecules right here. So you will collapse this. It will lead to atelectasis. That's why we don't like pneumothorax. There's another condition called pleural effusion. So the difference between the two, they're both here in the pleura. When you just see the word pneumothorax, you know that it refers to air. There's air here between the parietal and the visceral pleura. When you see this word pleural effusion, it's not air, it's fluid. There's fluid between the parietal and visceral pleura. How do you get fluid in there? A lot of times it can be because of infection or poor lymphatic drainage.
Can't you inhale it into your, like it goes down the wrong side?
No, no.
Inhale.
That's a very good question, but no.
Okay.
You know, this pleural effusion, you know when you have an infection, we know that they say, oh, you have swollen lymph nodes, that you have an infection. And you have to be treated, right? Swollen lymph nodes tells me that my lymphatic system or my immune system is working, but we don't want it to always be swollen. Because if there's any swelling, remember you saw the anatomy of your lymphatics, the afferent, many afferent, and there's only 2 or 3 efferent. So there's always a traffic jam, you remember, in the lymph nodes. Can you imagine if there's extreme swelling, you're going to cause lymphatic, what do you call this? A traffic jam, backflow. So there's a chance for the lymphatic fluid to seep out again. And if it's here, it can seep out here, leading to pleural effusion fluid, which can, again, possibly lead to atelectasis. So the problems here in the pleura, we worry about them because of what they can possibly do to your lungs.
Okay, so you said that there's pleural fluid in between the two membranes, but you don't want fluid in between the two membranes, so what
No,
fluid are we
no, no,
talking
no.
about?
There's fluid there, the fluid, there's normal fluid. This one is, you're talking about increase. If there's increase, we don't
Okay.
want increase. There's another one called empyema. I don't know if you've heard of this one. Empyema. This refers to pus, like pyuria, pus. So if we don't treat, a lot of cases of pleural effusion is secondary to infection. And if they don't get treated, they can lead to bacterial accumulation, pus. So now there's pus there. Okay? So we want to make sure we treat them. Okay? So now that we have studied these anatomical features, we're ready to study why we breathe. Let's take a break for 5 minutes.